Uh, yeah. Thank you so much for the opportunity. And as the topic discussed today, we want to talk about composite resins. 1 minute. Just 1 minute. Yeah. Once you start recording, my system has to accept it again. Yeah. Just a minute. Sorry, guys.
Sure, sir. No problem. All of
Because
you, please switch on your videos, guys.
yeah. So once somebody starts recording, my system needs to get it approved. Yeah. Sorry for that. Today topic is on recreating nature with composites. So in this 1 hour, I'll try to cover up what can give you a better resin output, what you're looking at. I'll try to cover up the topics on shade selection and also finishing and polishing techniques. That's it. No problem. This is going to, sorry about that. And as she introduced, I'm from Chennai, the south of India. So anybody coming to Chennai, please be my guest. We will be happy to show through our facility here. So I have my regular OP here. Then I have my training center here, as Dr. Bharti was mentioning, where we train dentists on the latest techniques and materials. It's a small grouped discussion what happens in a training center, and also have my own digital setup. So that's our laboratory. We also have a dedicated cosmetic center. So anybody coming here, please be my guest. I'll be more than happy to show you through a facility. Please keep me posted. I'm going to share my contact details. Anything further, you can always ask me any questions in this regard. Apart from dentistry, there are two things which really attract me. Is one is cooking. So after lunch, that's always the most toughest thing to take a lecture is anyway, you're not right in front of me. I don't know how many want to sleep, but I'll make sure that none of you sleep. So after lunch session is always tough, very difficult. So I love cooking, to be very frank. And I'm also a certified fitness coach. I realized I've been into this field for almost a decade. So I realized that focus is very important in life. Forget about dentistry. So focus is very important in our life, then our profession also. So when you're mentally fit, everything comes. Mental fitness comes with physical fitness. I learned a lot of lessons during my journey. I also help people achieve their goals with regard to fitness. So that is one of my other, which I generally don't share it in my CV, but I tell it everybody that apart from dentistry, if you're looking into some weight loss, some muscle gain or something, we have done a lot of scientific research in this regard, and we're able to give some scientific data on based on which you can achieve your goals. Having told that, this is very important for me. This video is just not to show off what has been happening in my life. Every day morning by 6, I'm there and the progress. Why is that? When you look at this video, so I'm trying to lift something uh, which is 120 kgs. That is the new challenge or what we have gained. But when you're going to push your horizon, not stay there, you always take a chance and see how things move. You don't stay there. You always try to move a little up and see if you can push. And that was 130, which is the next step what you go. And I tried. I always love to do this because you need to push your horizons and see where you are standing. And you see that I've given up. I've given up only for that day, but not fully. I did not lift it. So this rule is very important for me on a professional basis. Maybe I didn't do it today, but I'll for sure do it tomorrow. So guys who are listening to me, composite resin today came beautifully for me. Not by luck, but by science. So you feel that today it's come out well, tomorrow if it not comes out well, then it is not scientifically based. Today I'm not getting it, tomorrow I'm not getting it. That again means that you're not going to get it at all. So please be sure that keep trying. One day it will come. So this fitness journey has changed my life and my profession in a very, very strong way, that we always talk about a courage. I define courage here as not as a violent noise, but a silent voice which tells at the end of the day that tomorrow I will try it again. So this has been my journey for all these years in recreating art. Composite resin is basically an art what you're creating. So please guys, it's just not that you're not in the right mind frame or you're not able to create something, then don't do it. Your mind should be like a painting, like what you see right in front of you. You are recreating what nature has given. That's all. That is the best form what you can do. And the only variability can be the hand skill. So that's what I tell my participants also. So I can teach you everything, how to bond, how to get the right shade. Everything is crystal clear. Dot to dot, there is a protocol to be followed. But the final outcome is actually coming only from the hand skill. So please, that is the only variable in the room is the hand skill of somebody. So once you improve your hand skill, things will really, really get better. So I'm going to talk about a lot of things about shade, especially, and finishing and polishing techniques and the layering technique. So you'll understand the concepts. So that's where everybody will tell. Of course, in this 1 hour lecture, I cannot be able to cover everything, but I picked it up, the shade and the finishing and polishing, which is the two key factors for shade blending. But before that, I would love to give a small introduction on the field of cosmetic dentistry and why composite is slightly laid back compared to other materials, especially ceramics. So the number one question is dentistry the same? Dentistry is definitely not the same. There has been a huge paradigm shift from need-based dentistry to want-based dentistry. What am I meaning by that is that there was a necessity for the patient to walk into my practice. Doc, it's paining. Can you take care of something? But now more and more patients are coming in. Doctor, can you look at my teeth? Can you change the shape? Can you change the shade? I'm not happy with the alignment. So a lot of patients are coming and walking into us for the reason which they want. Do they really need it? Maybe not. So for example, if this patient is walking in, 100% the patient is not going to die with this. 100% it's not a disease. So they have lost a portion of the tooth structure, which we are going to recreate in such a way that it is completely invisible. That's what we tell. Whatever dentistry we do should be completely invisible, just vanishing with the existing hard and soft tissue. So this is an art which is purely scientifically backed up. So every smile we create should be an art what we create in the patient's mouth. But please remember, it's with scientific background. That without science cannot stay for long. But in this, what has happened in the recent past is that we know that the role of social media is so much today that people think that that is life. It's a bubble which is going to burst. For example, don't be surprised with the next two slides what you're going to see, because that is a survey that's been done and it's going to get published. When I talk about dental diseases, you know something? It's, oh, I know caries, I know periodontitis. Yeah, that's what we read. That's what I read 25 years or almost 30 years back as an undergrad. There was a hard tissue disease and there is soft tissue disease. Hard tissue disease can be biological, can be non-biological. So caries, non-caries lesion, biofilm mediated, non. The terminology changed. But it's so hard for me to see the new dental diseases that's coming up. What are the new dental diseases? Poor quality dentistry, wrong dentistry, and quick dentistry. It is so unfortunate. A survey again which states that when you look back, every 8 patients or the 10 patients you see are retreatment. The patients are getting either retreated because they're not happy with the treatment, or they are not having some pain, or they did not get the outcome they wanted. So what is this poor quality dentistry, wrong dentistry, or quick dentistry? I'm going to show you pictures, which are the patients who I treated. It's actually increasing on a higher side. What is poor quality dentistry? 100%, this is not the outcome what somebody is looking at, right? Maybe the patient required all crowns or laminates, but it is not of the right quality what the patient is expecting. Okay, this is okay. At least the treatment planning is not wrong. This is again poor quality dentistry. No restoration is staying. My patient is coming, doctor, I need something permanent. So the quality wise it's compromised, but at least the treatment planning was correct in these cases. But cases like this are wrong dentistry. And wrong dentistry is that patient went in for diastema and what he got is 4 crowns, which is absolutely wrong. What can be wound up with composite was unnecessarily touched with burr to create crowns. So this is what we call it as wrong dentistry. So wrong dentistry means there is a problem in the treatment planning. So most often, why does this happen is that the incapability of a dentist to do a right composite is what is gone and made the dentist do crowns. So composites, according to me, is the bread and butter. We need to somehow master that, get the good bond, get the good knowledge on bonding so that you're able to better bond. Because I saw a lot of questions that came up also, which is always revolving around the bonding. So understanding the bonding strategies are very important so that your restoration, your dentistry stays. The more you're able to bond it properly, the less tooth are you going to remove. So please make sure that the first part is to know your bonding so that your tooth reductions are very, very minimal. And what is quick dentistry? Quick dentistry is, it shocks me when somebody tells that the smile makeover was done in a week's time. So this is what is smile makeover done in a week's time. An ortho case was done with crown and bridges, which the patient came back to me not with anesthetic restoration, but TMJ problem. So this patient was all good preoperatively, but has become deceased after the treatment. So, guys, this is not my slide. This is the patients are mine, but what I'm speaking is global platform release. So these three are three common dental diseases, what people are talking about: wrong dentistry, poor quality dentistry, and quick dentistry. And it was surprising that this is becoming common. Earlier, people used to tell that, okay, you remove caries, then you do root canal, then you do endo, then finally you land up an implant. So if something is not done properly, then finally you blame the procedure and tell that anyway the tooth is going to get extracted, why do you want to get a root canal? No, it is not that question. Now so far it was only the left side of your screen which was talked about, but today the right side of the screen is what is getting very, very popular. So what could have been done with no prep dentistry is now going into prep dentistry, and eventually we are also losing teeth because of aesthetic treatment. When Dr. Bharati introduced me, she was telling cosmetic dentistry. Yeah, cosmetic dentistry is catching up. In fact, now forget about dentistry. In cosmetics, every aspect of, you take the hair, you take the skin, you take every damn thing. Today, cosmetics is the top thing. So people want to look beautiful, and smile is an integral part of that. And are we doing it right? So these patients are walking in healthy and they have to leave your office healthy. They cannot get deceased. So please keep that in mind. As a request, I'm just telling everybody here that we have to satisfy the patient needs within the zone. The zone is very important for me. If it's not within the zone, I'm not touching the patient. Simple. So as much as possible, what happens is that with composites, so very easy to achieve and stay within the zone. In fact, our Bible is Peter Dawson textbook, Functional Occlusion from TMJ to Smile Designing. He passed away before COVID, and he tells that, I've gone training with him. He beautifully tells that the goal of an aesthetic makeover is to develop a stable stomatognatic system. So unless you develop a stable stomatognatic system, you're making the patient deceased. So let's be clear that we are recreating the nature in the best possible way. So I always tell that nobody goes wrong with diagnosis, but treatment planning is what that can be varied in a room. So the diagnosis of this, what you're seeing right in front of your screen, is a fractured tooth. Maybe it's vital, maybe it's non-vital, that all is secondary, but it's a fractured tooth because of some trauma, and to recreate it, right? So how all can I do? There are only two restorative methods. One is going to be either composite, or they're going to be indirect, which is going to be your glass ceramics. So both can be done. But when I do composites, the tooth structure reduction is very, very minimal. When I'm doing an indirect, the tooth structure is reduced highly. That means I'm risking my biomechanics. There is always a possibility that my remaining tooth structure is gone. Why do people shift is that we are not able to create the same effect what nature has given. And I repeat, this is an art and a doable art. That's what I'm right in front of here to tell you that though there are two restorative materials, keep composite as your first choice. Wherever possible, try to fit in composite. But if you're not able to fit in composite, then move to ceramics. So most of the cases would fit in with composites except two reasons: discolorations. I will never play with discolorations because composites cannot mask discolorations 100%. The next thing is that if I'm removing enamel, probably the size of the tooth was bigger. I need to reduce the size. I'm cutting enamel, then I don't replace it with composites because I need to replace it with enamel like material, which is none other than ceramics. So these are the only two reasons where I actually wind up my case with ceramics. Otherwise, most of my cases are done only with composites. Now, why is that fear, and why every time we talk about composite, people always want to know, can I do it with composite? Can I achieve lifelike restoration? So what you see right in front of you should be a dentistry that's done that nobody should be able to find out what's been done, right? So for your information, the tooth that is restored is the right central incisor with composites. So what I'm trying to tell you is that this is doable. It's not that it's not doable, and it's restored with composites. So only there is a workflow, a protocol you follow so that you will be able to do what you want to do with resins itself. The lesser understanding of the resins and the constant evolution of the resin is what made the clinician the fear of achieving what they want to achieve with direct restoratives. So the minute you know what is there in the market and the technology, why there is another sad story, because most often in the colleges, what they teach and the importance is given is to other than composite, but unfortunately composites play a major role for us in day-to-day practice. So it is very important that this question of can I do lifelike restoration should go away from your mind. Take up this challenge like I showed you in the first video. Today, I'm not able to do it, but tomorrow, 100% I'll be able to do it. So there is a lot of difference. Today, I got it by luck. Tomorrow, will I get it? It's a question. No, not like that. Today, I didn't get it. Tomorrow, will I get it? Both should be, I will be able to get it. So I follow a simple policy. If I can do it, everybody else can do it. So please remember this lifelike appearance is more achievable, not with prayers, but with science. Now, coming on to science, people always think that once we are out of college, that's all, studies are done. No, it doesn't happen that way, because there is a constant uh, evolution that's happening with regard to the material science so that we are able to achieve what we want. So we need to understand what's happening so that we are able to stay updated and get the results what you're looking at. So now I have this biggest university, which is a troublemaker in our practice, is this Instagram. So this Instagram is considered giving a lot of information. And I was recently in a lecture on artificial intelligence. The first slide that came up there was, you read it for yourself. Don't believe in anything you see in the media. It is so scary, guys. You don't know where we are in AI, that is artificial, that is nothing. Then you have automation, then you have robotics. These are three phases in AI. They have developed robots that can think on its own. It's very scary out there. So the next video I'm going to play, so people who know me here already know that I cannot speak one single word out of Hindi. So listen to this.
इतना गर्मजोशी भरा स्वागत है मेरे प्रिय मित्रों और सहयोगियों। दंत चिकित्सा में बहुत सारे बदलाव हुए हैं, खासकर डिजिटल क्रांति के साथ। और क्या हम वहां हैं?
That's not me. I'm right in front of you, but that's not me. That's AI generated. So guys, go back to books and start reading. That's the way we gain knowledge. Knowledge should be the strength in which you work. So like Stephen Hawking told, the illusion of knowledge is the greatest enemy, is having a illusion that we know everything. So please search for knowledge to get what we want. And today's topic revolves around composite resins. I'm going to split it up into two major things. One is shade selection, and other is going to be finishing and polishing. So shade selection is what everybody talks about. That is the material science. And I'm going to talk about the essence of finishing and polishing. The number one complaint what everybody tells is that my shade is not matching. Realizing the fact if your shade is matching, the job is 90% done. So I want to concentrate on how to get the shade matching or selection, but rather I would call it as shade blending, because you cannot match nature. It's how you blend shades. So when there is a debate between shade versus shape, please remember it is a shape that wins. So there are two categories here in the human psychology. So what human psychology tells is that when you want to describe somebody, you tell that guy was very tall, is very thin. We always concentrate on the shape, and that's why today you see a lot of slim clinics. Everybody wants to look slim and beautiful because you are attracted by that skin tone. I'm not bothered. Everybody knows that I cannot become fair, but at least know that stay in shape. So shape is what that attracts the human's eyes. So if you get the right shape, 99% of your shade problem is solved. So guys, remember, shade is a myth. There are a lot of factors which I'm going to discuss now, though it's post-lunch. There's a lot of science which I want to tell you, which will open up your eyes and look into your composite at a different angle. I'm not here to tell you by this, by that. That's the most stupidest thing what I'll do. I want you to understand the materials, what you have within you, so that you're able to practice predictable dentistry. So the shape is so very important, and where we start our programs is all drawing. So we did this as second grad, but today we started teaching when you're doing advanced workshops. So all these drawings are handmade. So if you're able to do these handmade drawings, that'll be the best thing what you can do justice to your composites. So I strongly recommend that you have a lot of YouTube videos. You can see them and start drawing or take up some drawing classes to get your hand tuned. Those who feel that I'm little lacking in my skill, because everybody cannot be the same. So if you want to improve the skills, don't work on composites. The first, you're going to work on a paper and a pencil. That's drawing. The next is going to be wax buildups. Only the third is going to be the composite. So when we talk about shade matching, we talk about hue, value, and chroma. Everybody knows that what is a big deal. But the big deal is that all our patients are not bothered about that. Your patient going to tell that, oh my God, it's looking bright, it's looking dull. So value is the most critical component to match, and value is given by enamel, and hue and chroma is given by dentine. What does that mean to me? Why are you talking this to me? So the lightness and the darkness of your composite is more important than actually the A2, B2, or whatever it is. That what is the most common shade all of you use is A2. Globally, they have found out that A2 is the most common shade that's been used, and also the most common shade any company manufactures. Then why do you talk about shade matching? The same A2 can behave differently in different thickness. That is where the problem started. So let's understand what exactly enamel and dentine is. So dentine is, we all know that it has got an organic component and also an inorganic component. Whereas enamel is a pure inorganic component. So enamel is more translucent, modulates the color, whereas dentine gives the exact opacity that is required. So if you are not able to understand this, you will not be able to do shade matching at all. So material that's used for dentine replacement should be slightly opaque. A material that's used for enamel should be slightly translucency. By altering the thickness, you can just alter the shade. So A2 and B2, does it really mean anything? No, it doesn't really mean anything. You can cheat your eyes altering the thickness. So what am I talking? What is that? Do you have to have so many tubes like doing a research? No, you don't have to have so many tubes like you're doing a big research at all. Once you understand what you need, then you will know what you want. Like I told you, there are two biomaterials what we are dealing with. One is the dentine and other is the enamel. So dentine is more opaque compared to enamel. So dentine is a bigger particle size. Enamel is a smaller particle size, which is translucent. So basically, you need two different materials that is required to do a beautiful layered composite. Especially, I'm going to talk about that also in a layering technique. When do I follow is only when you do a class 4. Other things you can do away with one shade of composite. I'm going to talk what is the current generation. So basically, I'm looking at a composite which is slightly opaque in color, composite which is slightly translucent. So with this, I'm able to layer and get the same biomaterial effect what comes there finally. So today, taking away the shades off. So moving forward, every company is going to come and sell you, doc, this is a universal composite. What do we mean by universal composite is that they will not have shades. It's your capacity to alter the thickness of this material and use it as an enamel or a dentine. That's all. That's all is the company is going to come and tell you. So already there are, I don't know how many of you have heard of Omnichroma, Tokyoma. All these are coming and selling shadeless composites. So guys, I want you to remember this is a very important slide for me. You have three categories of composite that you need to have today in your armament. I'm not selling products. I'm selling you techniques. So achromatic enamel, and opaque or dentine shade. What shade? I don't know. Whatever shade it is going to blend well. So what is achromatic enamel? Achromatic enamel is completely translucent. It doesn't have anything. So you have incisal translucency, then you use an achromatic enamel. That means this enamel does not have any shade within it. Chromatic enamel is translucent, but still has got an yellowish tinge or a bright B tinge. So maybe you can have A2, B2, done. Then every company sells you opaque or dentine shades. So basically, I'm looking at an transparent shade, which is a selling terminology, young enamel. I think you would have heard of all this. Young enamel, T shade, enamel shades, all are achromatic translucent composite, which is used at the incisal edge. Chromatic enamel is the one which is used on the topmost layer. That comes as A2, B2. That's what we call it as body shades. And opaque or dentine is at OA2, dentine A2. All these stands are the material that has to be used. So this is what is the cross section of the tooth structure, which tells you why do I need that. So basically you have the dentine, which is topped up by the enamel. At the incisal edge, you have only the enamel, which is completely translucent. So when I'm doing an incisal edge build up, I always require that translucency. Then I put my dentine layer, then I put my enamel layer. You need to do this when you're doing all class 4s. Let's look into it a little later. But first, I want you to understand what is chromatic enamel, what is achromatic enamel, and what is. So guys, moving forward, all companies going to come and sell you Doc Universal Composite. So universal composite is that they have removed the shades, but giving you in translucencies and different opacities. You're going to get a completely translucent, a minimal translucent, very minimal translucent composite. A very minimal translucent composite is the opaque composite. A translucent composite is okay, can be used. A super high translucent composite used at the incisal edge. What shade? I don't know what shade it is. So that is how every companies, already some companies are there. So incisal edge is a trans, then enamel is the achromatic, which can be A2 or B2. Some people will still stick on to A2 and B2, but some will take it away. Dentine will come to you as A2 dentine or opaque dentine. So guys, all you need is only 3 tubes of different translucencies and not different shades. Why all these change is they have understood that shade is a myth. It's not shade matching, it's a shade blend. So I'm going to talk about the science of this is that this is what Dieter Daichi proposed in the year 1995-97. A lot of articles have come is that the dentine and the enamel have their own tints, which we need to replicate when you're doing your restorations. So this is what is the layering technique, which was proposed way back in 1995 with the materials what was then had. So you look at the translucent layer. This is what is called a achromatic enamel. That means it's completely translucent. Then you put your opaque dentine, which is blocking the light, and then you put your enamel, that is a chromatic enamel, then all your restorations is beautifully done. So there are composites that are available in the market are called body shade composite. What are these body shades? A2, B2, that's all. Enamel dentine, nothing. A2. Even 3M gives you A2. Shofu gives you A2. Every company gives you A2. What is that called as body shade? You can either use it as enamel or dentine depending upon the thickness. On the other hand, there is another company which gives you A2 dentine, A2 enamel, but these are very, very expensive. These are like Benz class product. Can everybody use it? No, I don't think everybody can buy because what you got it for 2,500. This one tube of A2 enamel is going to cost you 5 grand. So it's not everybody's cup of product, but everybody wants to have the same result that led to the development of newer products in the horizon, which people started to name it as shadeless composite or universal composite. This is the recent technology that's developed and coming up in the market. I'm sure everybody would have heard of this Topaz 1 from Pulsar, Tokyoma Omnichroma, Tetric N2, all this are different filler particles which allow you to shade blend if you understand the translucency levels and opacity levels. So a 20-year-old young individual has got a lot of translucency. That means my thickness of my restoration of that layer will be thin. My 70-year-old patient or a 60-year-old patient, you have a opacity that is set in. So the thickness of the dentine layer is going to be more compared to that. So that's how you shade blend, and you don't pick up, oh, A2, B2. No, do not complain like that. I should have used B2 here. No, please remember, it is altering the translucency is what is going to alter in all these. So the question is that, can I use this in all situations? What I today called it as universal composites. No, you cannot. Even the companies which sell you Omnichrome or Topaz One, they tell doctor, please buy 1 tube of opaquer, because you can use them for diastemas. One shade, whatever shade it is going to blend because of the refractive index or the index of refraction. So this is called refractive index optimized technology, wherein the filler particles spread the light within the tooth structure and give a myth of shade blend. So if you're doing a diastema, a small class 3, a class 5, class 1, class 2, every situation, no problem. But the minute you land in two situations, a class 4 and a through and through class 3, then you will need a dentine shade. I call it dentine, people sell it as opaque. 3M sell OA2, Omnichrome sell this as opaquer. Opaquer means it's a stop of light not going through like a dentine. If light is going through and through, then all your teeth will apply dark, because inside the mouth it's dark. Nobody's putting a torchlight inside. That's why you tell that I did a beautiful restoration, but it's looking gray in color. That's because the thickness was not sufficient. So exactly remember, getting the right thickness is what is very, very important. Like I described, incisal translucency, then you have the A2, B2, and then you have the A2 dentine. This is what we require for us to do this beautiful work. So again, sorry, to repeat, value is the most critical component to match. Values given by enamel, hue and chromas given by dentine. I was telling about the thickness, right? I'm going to give you, it's not a rocket science experiment, but look at these small videos, what I've made for you. So now glass is transparent, everybody knows that. And look how the letters slowly fade when the thickness of the glass increases. So we all know that glass is transparent, but when the thickness increases, the refraction changes and the clarity gets dipped down. So please remember that the thickness is going to play a huge role. Look at that clarity. Now coming on to colors. So look at the same pink. What happens is that when the thickness of the pink increases, the chromacity increases. So please remember, if the shade is not matching properly, it is the thickness of the composite where it is going wrong. Either you made it too thin or too thick. When the composite appears dark in color, that means the thickness was not sufficient. It's not about the shade, it's about the thickness. Please remember, don't blame the shade of the composite. It's the thickness. The same composite can be the shade, but we have screwed up because there was no sufficient thickness. So thickness is the key, guys. When the shade is not blending, don't check your shade, check your thickness. Look at that. The same pink, that's all. But the mouth is not white. It's dark in color. Look at the value dip when you're putting the same pink in a black background, which is the mouth. So understand the shade and the effect of every thickness you add and the final outcome you come clinically. So what is the lesson learned here is that I don't want anybody hearing to my lecture change the composite what you're using today. You use the same composite what you've been using, but only do not buy a different company composite next time. Why? Because it's like cooking. I told I love cooking. So when you do the same recipe over and over again, you know that if you add this much amount of salt, what will happen? If you add this much amount of salt, what will eventually happen? So you would become a master of the composite that's in your kitchen, that in what thickness, what effect would come. Am I clear, guys? So don't keep buying. Okay, this time this guy is giving me some offer. Next time next guy is giving me some. Please don't do that, because shade is not the criteria, the thickness. So in your experience, you should find out that in this thickness, this is the shade what I get. In this thickness, this is the what shade what I get. So altering the thickness alters the shade. I can't make it even more simple. Shade, thickness increases, value changes. What your doctor is looking dark, that means the thickness is not sufficient. You made it too thin. So in our hands-on, that's what we tell, that when something gets translucent, it lowers the value. Lowers the value means it start appearing dark. So you feel that, hey, the shade was A2, but it's looking bad. It's looking gray. That's because the A2 did not have that thickness what was supposed to have. So please understand, do not blame the shade. It's only the thickness. That is why today all companies are going to come and knock your doors telling that, doc, universal composite. What is universal? No shade. Then you tell no shade. You know, when 1955 Bowen introduced and 1970 when the first composite was introduced, the Hercules and Concise, they did not have shade. Life is a huge cycle. We have again gone back to history, no shades. So already composites are there in the market. So please be prepared. Every company is going to come and knock your doors with universal composite. What are universal composite? I have different translucencies. Translucent, chromatic enamel, and opaque. Only three. What shade? No shade. Translucency difference. So shade blending not happening are two factors. Insufficient thickness. The next is improper polishing techniques. Now, what is this? Why polishing going to bother? Sometimes you do the build up, it looks wow, amazing. Then you start polishing, then you feel, oh my God, it's become gray in color. Everybody, even I experience that. There is a reason for it. So what am I trying to tell you as a clinical tip is that do not finish and polish at the same day. Any textbook? No, no textbook. This is a clinical tip. Why? Number one factor, I take 45 minutes to do a build up, and then my assistant is tired before anybody else. Okay. My patient's also tired. Even I'm tired. More than that, every other tooth gets dehydrated. Theoretically, it takes 48 hours to 7 days to become hydrated to get a shade blend. Every other tooth will look whitish. Your compost will look dark. Have you noticed the white spots coming when you, because I'm a use Rabadam, I'm a use any retracting devices, it's dry off saliva. Patient doctor is looking dark. I tell don't look at it now. Take 24 hours before it settles down. I call the patient the next time and see if the shade is blending or not blending. If it's not blending, I know it's because of thickness. I alter the thickness. Once it's blended, then I start my finishing. If the shade is not blending with the finishing and after finishing and polishing, the flaw was with finishing and polishing. Without knowing, you did finishing and polishing and build up and wow, look at it, it's looking bad. Then you don't know what went wrong, whether it went wrong with the thickness or whether it went wrong with the finishing and polishing. So you need to understand, get the problem. What was the problem? I didn't know what was the problem. So there are only two problems that can happen. One, insufficient thickness of your composite can result in a shade mismatch. Improper finishing and polishing can, so split it up. Halfway, I was right. The next half went wrong. So I know where to correct. So what is this about finishing and polishing is that surface texture. So if you sit down and finish and polish like a marble, it'll appear dark because there are sharp reflections that emerge out of smooth surface. That means if your surface is nice and smooth, beautifully it'll start reflecting light and they will appear dark in color. The same thing when it's matted, it'll have a different texture. I'm going to show you again another science, not a big rocket science experiment. Textures create high value. Weak textures create low value. Now look at this picture. One side of your screen has a plain white paper. Other side of your screen has a crushed white paper. I don't have to tell you that the crushed white paper appears brighter. So if you polish it like a marble, it will definitely collapse and you will not be able to get a beautiful bright. Suddenly after polishing it became dark. That means your texture was not insufficient. So please remember that giving texture is very, very important. Then finally, a little bit about getting a beautiful restoration is adding little colors to it. Is this mandatory? Right now, not mandatory, but keep that in your bucket list. So eventually I would love to add some colors so that it looks more lifelike. So this is going one stage, one stage, one stage. First getting the right restoration, then adding, oh my God, I want to improve. I want to improve are using these colors or tints. So there are a variety of colors or tints, and I'm sure you would have seen them in Instagram. Everywhere it's flooded using the white color, the blue color, all that are getting the halo effect and the incisal translucencies. So there is a material from Ivoclar, which is an opal material, which is one of my favorite product, which people can message me. I can share my article. We all do scientific basis presentations only. So these are the articles which support that. Look at this material, which appears bluish and orangish, a typical inherent property of the hydroxyapatite crystals, which will opalescence. So I always have a tendency to add this opal material, which is the safest material to get the beautiful incisal translucencies. And I'm also proud at this moment to tell that we were the first to publish the article on incisal translucency guide. So this is the guide, what happens when you use blue, what happens when you use violet, what happens when you use blue and violet. So I'll try to share my article with you if you could message me in my Instagram or something. So finishing and polishing is important. Then another point is that I'm able to see a margin. It's also a part of shade blend. So there are two things which can happen is improper beveling and improper adaptation. Got it? So I'm going to take you through a step-by-step procedure. Now, having told all the theory, I want you to take you through the step-by-step procedure so that you get to see what happens. So I spoke about a bevel. So this is where people make a mistake. So there is nothing conservative once you start putting your aorta burr there. So give a nice bevel, a 45-degree bevel. I'll show you a video right now. The next few slides are going to be a video demonstration of how to give a bevel. And a nice bevel, a minimum 2 millimeter, or at least I give 3-4 millimeters equivalent to the defect, right? So before that, what I do is that I get my wax up done. I get my putty index done for the incisal build up. So this is the bevel, what you see. I'm going to talk about two bevels here. Look at this. This is a video. So I'm using a blue burr, a rotor, the middle of the burr to give my primary bevel. So this is what is my primary bevel. At a 45-degree angle. Nice bevel. Yes, this is the primary. Then I will use the tip of the burr to give my secondary bevel. This is very important in a curvature. This was earlier told as a star sky appearance or skirting, because if you don't do this and if you just give one primary bevel, the margin will be visible. Always try to rotate it so that you get a invisible margin. In the palatal side, you just give one primary bevel because secondary bevel is given only for aesthetic reasons and nothing else. Then comes your layering concept. So I'm not talking about a diastema. I want to talk about this class 4 because that is where is diastema nowadays. You can just manage with whatever. If your hand skill is good, done with everything. So I have a case here. Now the first layer is achromatic enamel. I am not here to sell a product. That's why I'm not using any product names here. People will sell it as translucent or young enamel. Every company has its own trade names. But for me, it is an achromatic enamel. What do I mean by an achromatic enamel? There is absolutely nothing. It's completely dot to dot transparent. You see this. I build it up. Then I use this putty index to do that. Once that is done, then I put my dentine layer or the opaque layer. You cannot do away with one shade. You need some opaque material to block the light. So once I've done that, I have an instrument to get the right thickness and then create these beautiful dentinal lobings. Now you can move forward with the composites what you have. In between the dentinal lobes, you can again put a T-shade, or later on in your life when you want to buy tints or colors, trans opal, which is what I suggest as the easy way out. I will fill up the dentinal lobes inside areas with trans opal and then finally place my chromatic enamel and finish the restoration. You understand? Achromatic enamel, opaque, chromatic enamel. I'm not talking about shades. What did it do? I gave a good bevel, I gave a good adaptation, and these are the brushes. These are special brushes, the ceramic brushes, so they will give a beautiful blend. So if you use them, so first thing is isolation, a good tooth preparation, bonding, and then placement of your composite, and layer by layer adding the right opacities and translucencies at the right thickness is what is going to give you the shade blend. Again, please remember, shape is the key. If you want to make it look natural, shape has to be there. What do I mean by shape is that, look at this, achromatic enamel, dentine, and then the chromatic enamel. Nobody should be able to find out what you have done. You see that? It's exactly mimicking, mirroring the next tooth. Look at that. Nobody should be able to find out. There's a lot of things that goes into this, and that's exactly where we are. When I convert it to black and white, that's how we actually check if it's visible or not visible. Nobody should be able to find out where the restoration or where the tooth structure is. So coming on to the finishing and polishing techniques before I wind up. So what do we do? Get the shape. So there are three types: primary anatomy, secondary anatomy, and tertiary anatomy, and getting the right textures, which I explained earlier. The textures, which I explained earlier, first use the blue burr in your air rotor, because I don't know how many of you seriously have this slow speed handpiece, but that's okay. You can use your blue burr, thin blue burr, remove all the surface flash, and then use your BP blade, interdental strip, to remove all and achieve the primary anatomy. Primary anatomy is a shape what you give with the line angles. So the all are three are incisors. So basically you're looking at square tooth, triangular tooth, and an ovoid tooth. You mark them on the pencil on the composite and try to get the right shape. This is very important. Now, this is called the finishing procedure. So all finishing procedures have to be done in slow speed without water. Please don't use water. It will clog. Am I clear? So please remove all these powders with three-way syringe, but never use water. Use the line angle as a guide. Then from red, you move to yellow. Okay. So first use the blue burr in aerotor, then you move to the red and yellow in slow speed. And then finally, you need to pre-polish. Pre-polish, there are two things. Pre-polish again comes with aerotor or slow speed handpiece. I love two things. One is a TC burr, which is a little difficult to procure. That is a 30 fluted TC burr from SS White or Brasler. Otherwise, you can use a silicone tip, what you use for polishing after oral prophylaxis, right? Even that can be used as a pre-polisher. Please remember, pre-polishing is very important. After pre-polishing is done, I create the secondary anatomy. What I told you to create the textures, right? So I create two Eiffel towers like this with the help of a small football shaped burr, like what you see here. So after the pre-polishing, I'm creating very small indentations, and the tertiary anatomy is the lines of perichymata, which will actually create those textures what I wanted and make my composite appear really, really nice and natural like this, what you saw. I use a thick burr and scratch it once and take my articulating paper and see if my restoration adjacent tooth has got the same texture. You can also use some food colors which are easily water soluble and check this, but articulating paper is enough. Then I go ahead with polishing. Any polishing system is okay, but work only at a speed of 12,000 to 15,000 RPM, not more than that. Is that clear? So work at that speed and polish it nice, and then you get a beautiful textured restoration. Fine. So there are a lot of steps that are involved, right from your tooth preparation to the right blend. It's all about blending. It's all not to do with the shade as such. There's a small video for you to see. So basically, shape is the key factor. So your hand skill should speak for yourself. Don't blame the materials. Don't blame the technique. These are the protocols what we follow, A to Z. So if something is going wrong, I've skipped a workflow from my side. So always remember that it's not about the composite what you're using, it's about the way in which you're using your composite. So get the right shape and a blend so that we use a lot of composites and never come back to the slide and see that I'm going to do something which is destructive, and at the age of 60, the patient is going to lose. In this, people ask also, there are a lot of questions. How long the longevity? I had a longevity of the composite fillings. Maintenance is very important. Why maintenance is that? It's not that you bought a BMW and then you're disappearing. No, it cannot happen. Every year you need to go for servicing, right? So my patient has to come back for servicing. Is that every year, maybe not the first year, from second year onwards, I start polishing, oral prophylaxis, polishing, and I apply fluor protector. Guys, this is very important. Today, it's a complete 100% important for all my patients to get fluor protector applied, either direct or indirect. So fluor protector is a protecting agent at the margin, because margin is where people tell that it's getting discolored or something. So there are two agents in this regard. One is MI varnish from GC, but I use that for fluoride application for the kids, but for the maintenance, I use this because the bioavailability of fluoride is very high and it's a varnish. It prevents any activity at your margin. That's where it fails. So how long? Theoretically, almost 6 to 7 years is what the lifespan, but an effective workflow, like this is a case of composite veneering wherein there is minimal tooth destructions, like what you say, only those cases we take up for composite veneering. And I have a follow-up of almost 12 years now. So this patient was very important for us because she came in the cover of the American Academy of Cosmetic Dentistry, Journal of Cosmetic Dentistry. So an Indian patient, the American Journal, and there she is after 12 years later, she comes, and that's a picture which I took last year. So guys, what more do you need? If something is done properly, it works for longer time. 12 years is a big period for composites, which we always advocate for ceramics too. So proper maintenance will be able to give you the right results what you're looking at. So I hope in this 1 hour you're able to learn something, have some questions to be answered also. So I strongly also take this opportunity to welcome to our conference on cosmetic dentistry here that's happening in Chennai. So there's going to be a very nice educative conference. So please don't miss it. Nice lineup of speakers. It's not another conference when a lot of people speak. It's only 4 speakers. Every speaker speaks for half a day. So August 28, 29, 30. If you're there, please do join us. It's going to be one worthwhile conference. After all, our policy is to make people smile the way in which they want. And thank you so much for this, spending this valuable 1 hour Friday afternoon with me. Hope I was able to answer your questions and deliver what you're looking at. I have some questions to be answered also. Are there any questions in the chat box also I can take up? I think you can ask me those questions. And this is my contact details. Expect a reply within 24 hours to 48 hours within you message me or mail me or Instagram direct message. You'll be able to share articles. That's my 3 ways of communication. The best way would be the mail or the WhatsApp message or Instagram. Anything is okay for me. And if there are any questions, I would love to take it up here, which I did not answer during the presentation was posteriors is not within the purview of this lecture, but people ask me posterior, do they debond? Yeah. See, you need to understand something. Anteriors, you can tell the patient not to bite, but in the posteriors, you cannot tell that. So the surface area of the bonding is very, very important. So you cannot prepare a small cavity and then tell that comp is going to stay. You need to prepare a nice cavity, improve the surface area so that your posterior restoration doesn't come. So do all composite take up food stains? No, when you're doing, I explained all that during all the finishing and polishing procedure. If they're done properly, most often you will not land up in any of the food stainings or other thing. Longevity, shrinkage, all is gone. So I will not want to compare apples with oranges. So there was questions on GACs and composite. I never even brought about GAC because GAC is not a restorative material. It's just to be used in non-load bearing areas. Maybe class 5s, yes. Glass enomer core build-up is also a question to me because only when the tooth is highly non-vital and I feel I cannot bond properly, only then it comes into my consideration. Otherwise, I don't want to compare apples and oranges. So composite is my choice in which we are able to do better restoration. So I hope I was able to do justice to the question that was pre-booked and answered. Anytime, please feel free to touch base with me. And since we have another 3 minutes time, I always give this leeway space so that I'm able to answer questions.
Sir,
What?
yeah, we
Say.
do have, sir. We do have few questions. Like, how do we understand the reasons for repeated debonding of anterior composites, even if no high points exist?
So, the bite force, actually, the chewing pattern. So, can I have the next question? By then, I'm going to pull up something and then.
Yes, sir. Yes, definitely. How to regulate thickness of composite for shade blending? Any tips?
So basically, all the restorations what are done are paper thick than the next tooth. How will my patient accept that? My patient will never accept that at all. So what I do is that generally during finishing and polishing, I keep it little thick and tell my patient that during finishing and polishing, I'm going to take it away. So don't worry. And when I finish and polish, my patient already forget about that and then they are all happy. So all my restorations are actually slightly thicker than the adjacent tooth, which nobody can find out other than the patient because the patient does this and sees thicker. See, you cannot find out how thick my tooth is. Nobody can find out. So playing with the thickness is a key, which once you do, only then you'll understand. So my restorations are always thicker than the next tooth. That improves the value and makes my restoration looks brighter. Over the period of time with the toothbrush, the composite also slightly wears away. That will also improve the longevity. While starting itself, you're making it very thin, then it's going to move away. So I would recommend that it's going to be very like a sheet of water thick than the next tooth.
Okay. Can we go to the next question, sir?
I'm going to answer this question. Why is my restoration debonding after following strictly all the protocols? Is that now look at this. 1 minute. I want to share this before I answer this question. So there was a Henry Marsh, a surgeon, who told that it took him 30 years to know when not to do surgery. I rephrase that. It takes 2 months for me to know composites. It took me 2 years to know when to do composite. It took me 20 years when not to do restoratives. After you did everything, and then it's breaking away, it's the chewing patterns. If somebody doesn't chew, nothing going to happen, right? So here is a case. My associate comes running to me and tell that, doc, I have a case. You're going to do a beautiful class 4 and show it in your next presentation. Did the patient ask for it? No. Did you yeah, I told my doctor's the best. You're going to do the best job. Patient is not interested. Oh yeah. Okay, I went and I see this. Lot of clearance, everything can be done. But when you look at the palatal side, there's a lot of story which tells me here, the best bonding if I do is not going to stay because it's a constricted. So if your restorations, so we talk about that in our occlusion classes, if your restoration is breaking, that means the patient is in a constriction movement of pathway. I hope all of you must be knowing envelope of pathway, that the mandible moves. So it's all to do with your movement of your mandible, which is getting restricted, and every time it's going to knock off. So we have a calculation for this. In fact, the treatment suggested for this patient was to get an ortho done Move your front tooth, create those diastemas. Then, doctor, I don't want. I'll stay like this. Yeah, you stay like this. Otherwise, I'm going to see this patient every 6 months with the debonded restoration. So I think now it makes a lot of sense to know when not to do the restoration. Rather, that's what years of experience give you, is to understand when not to do. So when I now maybe did I develop this eye 25 years back when I started the practice? No. But today, the minute I see, I know I'm going to touch this patient, because if I touch, I know every 6 months. So guys, remember, understanding the chewing pathways is more important than actually doing the work. Pre-operatively judge, check your environment, check your environment. If you feel it's not comfortable, no, don't touch, because it's still the patient forces and you're forced to do, then the patient not come back and blame you. Doctor, you told, but I didn't listen. So please understand, if everything is right and if it's not working, it is a chewing pattern that's disturbing you.
Yeah, can we take up the next question, sir?
Yes, 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 yes.
Yeah, somebody is asking that how much of palatal bevel to give.
2 millimeters of palate. Sorry, I thought I told 2 millimeters of palatal bevel.
And is pre-polishing has to be dry or wet polishing?
If it's tungsten carbide, I do it wet. If it's a silicon cup, which you use it for after scaling, we use those. I prefer that one glass from Shofu, so you can actually do it without water.
Okay, which generation of bonding agent you are using? Somebody wants to know that.
I wish I had more time. We could talk about bonding, because we are living in 2025 and I use the adhesive that was given to us in 1998. So I use the 5th generation for all my anterior composite works.
Okay. Any insights on bonding protocols?
So
Sir?
basically, depends on the amount of enamel. So anteriors have a lot of enamel. So my preference for anteriors would be etch, rinse, and apply the bonding agent, the so-called 5th generation, or the one-step adhesive. That is, you etch, then you apply the bonding agent. Whereas on a day-to-day basis, it's universal adhesives. That's a 7th or something. But if it's a posteriors, I use my self-etch adhesive system, where more dentine is there. When more dentine is there, I don't generally etch.
Okay, sir. That instrument for checking the dentine thickness, somebody wants to know that.
So that's from Style Italiano kit. You don't have to buy the entire kit. There's an instrument. You probably message me, send me a picture of it. It's from Style Italiano. And now, if you don't want to spend so much, I think last time somebody came for me from another instrument, which is much more cheaper and economical, Indian made one. So there is also that's which is Indian made one available. Style Italiano is the one who introduced that instrument.
Yeah. Can we have one more last question, sir?
Yeah,
Please?
please. We have
How
time.
crucial is isolation in composite? Is rubber dam necessary?
This is a good question. So anteriors, it's okay, we can forgive you. Actually, what is more important is the dry operating field. How you achieve is completely based on your skills. When I'm doing a 3-7, I'm not a fool to tell you don't apply rubber dam. But anteriors, do I apply rubber dam? No, I don't apply. I use Operagate. I use Optradam. Probably when I'm doing lower anterior veneering, I apply rubber dam, but not for uppers. I don't do it. I don't mind telling it, because I need a good vision to see what's happening.
Okay. That's all for today. Thank you so much, sir, for enlightening with so many tips. I think it is basic, yet we have to learn a lot about it.
Yeah,
But still,
especially
thank
with the
you once
newer
again.
generation of this materials that are coming up, it's very important that we learn a lot of things.
Yeah. Thank you once again for your insights, sir. And I would like to thank all our participants also. Still the room is full. Okay. Thanks for making this webinar successful. Have a cool day ahead. I'll get in touch with you, sir.
Yeah, thank you so much. Thanks everybody for staying back. Thank you so much. Have a wonderful weekend. Happy Holi.
Thank you, sir, once again. Thank you all.
Okay.